Season 2, episode 4, lots of surprises incoming. Let's get started. Be-whoop.
Next.
Is Harlow feeling lightheaded or faint now?
It's not as bad as it was before, but my head still hurts.
Okay, so this is a really good example of what those who speak a different language, in this case, sign language, have to go through oftentimes in hospitals where we can do better. And I've made this mistake in the past. Whenever we have an interpreter, whether it's an iPad video interpreter or an actual living person interpreting, we need to face the patient and continue the conversation with the patient while allowing them to look at the interpreter for guidance, because there's a lot of human interaction that happens that is nonverbal, that is important for them to grasp. And when you're interacting with a patient who is perhaps hard of hearing or deaf, some may be comfortable lip reading, but that can get tricky at times when there are new diagnoses made that they're not aware of, or medications that are very difficult to pronounce, therefore lip read. That's why every now and then in checking in and making sure that the way that you're communicating is still optimal for them. And if you are gonna be using difficult terms, adding in a second layer, writing them down or showing pictures or images.
And now my stomach does too.
What did she eat?
Yeah, so like this issue of speaking to the interpreter rather than the patient is one that I have made in the past and definitely have learned from.
It's okay to look at me.
I'm sorry. We're gonna get started with some blood tests.
And another good intention that actually has bad outcomes because it makes it more difficult to communicate is when people try to over-enunciate when they're speaking to someone who is hard of hearing or perhaps deaf, and it actually makes it difficult to understand what they're saying, or especially raising the volume. That may not be necessary.
Good news. Nose swab came back negative for COVID, influenza, and RSV.
Usually it's a whole viral respiratory panel of all sorts of viruses, metapneumovirus, parainfluenza, I don't know why I'm blanking on viruses, but there's a lot of them.
But a lot of other viruses can cause a cough.
Lucky me.
You can take off your mask.
Well, wait. If she has a virus and you're diagnosing her with one that is not one of the 3 you've tested for, perhaps we should still keep the mask on for respiratory precautions?
Your oxygen level is down since we checked you an hour ago, and your temp is up to 102.4. Let's get you some Tylenol.
Have you been outside today? It's already stifling.
Tylenol doesn't really make sense here. Figuring out why the temperature is spiking is probably the more important thing, because when a person has an underlying illness, let's say a viral respiratory infection, they can get a bacterial supra-infection on top of it. And that's usually symbolized by a fever curve that is downtrending over several days and then randomly spikes back up with worsening symptoms. And if that's what's happening here, I would investigate for a bacterial cause of this cough rather than just treat with Tylenol, an antipyretic fever medication.
Could be heat related.
It's not heat related. No one is hanging out in the hospital with an oxygen sat that's dropping with a temperature of 102.
But we're gonna take you back to the big ER for full evaluation.
Can't you just write me a prescription for some medicine? I'm sure it's just a summer cold.
Got somewhere to be?
Work.
I don't know how you guys do it. Live together and work together?
It's my cross to bear.
I love that they're charting. I think this is the first time that I've seen them spend extended periods of time in front of the computers, which we do a lot.
Dr. Santos, making progress on your charting, I hope.
That's the conversation I have every week.
Deficient charts leave a gap for the providers who give continuity of care and delays hospital billing.
I always try, and even if my note is not complete, to complete the after-visit summary, summarizing to the patient so that they know what we diagnosed them with, what the plan is, but also that allows the future providers, even if they're seeing them the following day and your note's not complete, an idea of what the diagnosis was, what the plan was, etc.
Who do we have here?
Jean Samba, 54, half an hour of left-sided chest pain, history of hypertension on lisinopril and Crestor.
So he has high blood pressure, he has high cholesterol, and he's having left-sided chest pain. In a situation like this, you want to get an EKG right away to see if there's any ST elevations or depressions, which are signs that a person might be having a heart attack. There are obviously other signs that we look for as well on the EKG, but those are the more common ones. And then we draw these enzymes called troponins to see if there's cardiac muscle damage, which leak in into the blood, and we get them in a sequence over a period of time to see if they're trending upwards, trending downwards, etc.
Some relief with 2-nitro.
Nitro is a medication that we give to vasodilate blood vessels to allow perfusion of the heart.
Decent vitals, no STEMI on 12 lead, gave him 324 chewable aspirin.
We used to have this reflexive recommendation that if someone was experiencing chest pain to take aspirin. We've kind of moved away from that reflexively. We want people to be given that guidance by someone with medical experience because there have been side effects as a result of people taking them inappropriately. Because if you confuse a different condition for a heart attack and you end up taking aspirin, there is a world where you can bleed internally. So it really needs to be thought about a bit more, which is why having a good relationship with your doctor and planning for these worst case outcomes is really smart.
Okay, we're gonna give you a full evaluation, sir.
I would like to know more in-depth history on a patient like this. Do we know if he's ever had a heart attack before? Because if he has had one, that puts him at a much higher risk for having a heart attack in the future.
And who do we have here?
Vince Cole, 23, fell through the skylight of a florist shop, then beat down to a bunch of ferns, complained of headache, asking repetitive questions, and only response to pain.
So he's obviously having some neurologic damage, could be related from a very heavy brain injury from a brain bleed or something like a concussion, but obviously needs further evaluation.
Multiple lacks in the glass, BP 118/72.
Stable blood pressure, meaning that he's not hypotensive, he's not losing a lot of blood or fluids.
Were you with him?
Yeah, we were parkouring and he overshot a Congo.
Oh, parkour, that's the thing from The Office.
Parkour! Pupils are equal and reactive.
What do you got?
Yeah, 10-foot fall, altered.
That's a long way down.
10 feet is the threshold for trauma center activation. 10 feet, 10% mortality.
0%. Anything over 0% is a concern.
Somebody's annoying and it's not me.
The gunner mentality is in full effect. He's trying to pull out random stats that he read out of the textbook in order to flex on his fellow colleagues. And if you do that and get it wrong, oof. It's much better that if someone calls on you asking you that question, and if you were to get it wrong, it's okay because you were called upon, than if you were volunteering wrong information to show off. Remember, mechanism of injury is part of the evaluation in deciding whether or not someone needs imaging, and a fall from that height absolutely warrants imaging, pan scanning, etc. You also want to establish the Glasgow Coma Scale to decide if this person can protect their airway. If they can't, they might need to be intubated.
Ogilvy, Joy, GCS, please.
Open your eyes, sir. 2 for eyes, 2 for verbal.
Good lung sliding bilaterally.
Joy, finish GCS.
Squeeze my hand. He gets a 4 for motor.
Pulse ox 99, heart rate 102, blood pressure 114/78.
Somebody shooting a documentary here?
Whoa, 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 you can't film in here. We've got patient privacy laws. What happened to your hand?
Cut it.
Can somebody show Spielberg here out to the waiting room and get her registered at triage, please?
He's my creative partner. I have his written consent to film everything for our TikTok page.
A TikTok page. He's near death, and we're talking about a TikTok page. And it's not just for the privacy of this patient. While she's moving around the camera, there's also the privacy of all the other patients and the things that are being discussed, which is why it's unethical to film.
Pan scan head through pelvis. Let's get him to CT ASAP.
Absent gag. We need to intubate before CT.
So remember, even if someone has a GCS over 8, but they can't protect their airway because they have an absent gag reflex, there could be indication to intubate them nonetheless.
Can I do it? I'm keeping a procedure log and I need more intubations on this rotation.
If Dr. McKay wants to teach.
Sure.
Okay, I need suction, 802, accommodate, and sucks.
I love that he's full gunner mode right now. This is max gunner energy.
Ambitious. Reminds me of someone I know very well.
I wonder who she's talking about.
Can you not?
Yeah, sorry.
Hot off the press.
No STEMI. Doesn't need to go right to the cath lab. Orders are in.
This is the first EKG that I think I'm watching. I've seen on this show, but there are some ST depressions in V1, V2. I feel like they're showing this for a reason. Anterior ST depression. So even if you have a non-ST elevation MI, you'd still treat it medically, but there could be indication for intervention. You probably need to do a posterior EKG to rule out a posterior MI in a scenario like this.
Hey, Jesse? Do you think you could repeat this, but with the chest leads on his back?
Why?
T waves are kind of high with ST depression anterior.
We see ST depression all the time.
Yeah, but could be a posterior MI.
Yeah, so that pattern doesn't necessarily prove that someone is having a posterior MI. Remember, posterior meaning the posterior wall of the heart is impacted. And because of the way the electricity travels through the heart and gets shown on the EKG, this could be an ST elevation MI posteriorly, which then presents itself with a non-ST elevation MI in the anterior leads. It kind of throws you a bit, but it does happen. And the arteries that are most often implicated in this is the right coronary artery or the left circumflex, which end up giving circulation to the posterior descending artery, which is usually the one that's not getting enough circulation in a posterior MI. So that's why you need to take the clinical picture, the EKG picture, the treatment potential picture, and phase that all together in order to help the patient.
Run it by the attending. If they agree, we'll do it.
I mean, this guy has done all sorts of invasive medical procedures, but now he asked for an EKG to be done slightly differently, and he's getting shot down. This is probably the least realistic part of the show thus far.
This is Jada Davis, Jackson's sister.
Oh, thank you. Hi.
Is he okay? And why is he asleep?
He was uncooperative when he first arrived and needed to be sedated.
Uncooperative? That doesn't make any sense. What happened?
We're still trying to piece the story together. He was brought in by a campus security guard who tased him after he was allegedly combative and violent.
Wait, what do you mean tased him?
We've treated his injury, and now we're trying to understand why he was so agitated.
Okay, this doesn't sound like my brother.
Well, his drug screen came back negative, so now we're taking Jackson to get a CT scan of his brain to look for any abnormalities.
Can I go with him?
You can't go into the CT, but you can wait for him to come back.
See, I would reassure the patient's family member in a scenario like this and say that that's really helpful information that he's usually not like this, which strengthens our belief that something is going on, which is why we need to do all of these tests. Now, all of a sudden, instead of being argumentative, you're working together.
Just did my first ER intubation.
That's great, man. Such a prick. You got a second?
What's up?
12 lead on my chest pain patient shows no STEMI, but the anterior leads might be suspicious for a posterior MI.
Agreed.
Yeah, I was gonna repeat, but with the chest leads on the back.
V7 through V9, good idea.
I don't know why he needed clearance to do an EKG. And I think posterior wall is impacted in around 10%, fact check on screen, of all MIs in this scenario, so.
Hey, Dr. Robbie gave the go-ahead for the back leads.
Sorry, man. I gotta call a report on a septic patient going to the ICU.
Yeah.
Time to cath is of utmost importance, so making this diagnosis early is really important. I would not accept that answer, or I would go and do the EKG myself. Oh yeah, doing EKG sometimes is really frustrating, especially with gloves on, because those stickies sometimes stick to the gloves and then you're trying to peel off the glove.
What's wrong?
Some of the leads aren't sticking here.
And he's really sweaty, so wiping him down is smart.
I lay down now. I'm tired.
Yeah, see, to me, he's having a heart attack.
I'm having some trouble here with adherence.
Oh, of course you are. Try this.
Yeah, that makes sense.
That's the skin glue.
Do you mind if I paint some sticky stuff on you?
I'm not 100% sure why he has defibrillator patches on him, as if he went into cardiac arrest. Maybe from the ambulance? Bit strange.
Perfect, Mr. Samba. All good here.
Haley, dizzy.
We'll put you down in a second.
Oh.
Holy shit. ST elevation,
Yep.
V7, V8, V9. It's a posterior STEMI.
So what's interesting here is that depending on if the heart is left or right dominant, you're gonna have different blood vessels impacted. It's not like left versus right, like where it's found on the body. It's about which blood vessel on the heart is causing the lack of blood flow. In a right dominant patient, this would be the right coronary artery. In a left dominant patient, this would be the left circumflex artery. Sometimes there's a co-dominant where both supply it, but it's important to figure that out. When you do send the patient for cath lab, they'll be able to diagnose that issue with the catheterization, injecting the contrast, seeing the blood flow, deciding whether or not to put a single stent, multiple stents, etc.
It's the worst kind of heart attack. Mr. Samba? Mr. Samba!
Well, it's really great that he has the defibrillator pads on now because he's pulseless, I'm assuming, and will need chest compressions and potentially defibrillation if it is a shockable rhythm.
Hey, I could use a second set of hands here. Pulseless VTAC.
Pulseless VTAC is a shockable rhythm. You have the defibrillator pads on them. If they're active, you can shock the patient. But if you're having difficulty or the machine needs time to be set up, one person should be performing chest compressions first.
Start compressions.
Great job so far. Oh, the chest compressions isn't great. Oh no, the pit.
Okay, resume compressions. Code STEMI, it was posterior.
Yeah, good call.
You put the defib pads on? Yeah, just in case. Hold compressions.
I mean, that was really quick. You should be doing 2 minutes of compressions before you check pulse again and rhythm. Rusk? Do we have Rusk?
Normal sinus.
All right. You got a strong pulse, check a BP?
All right, we'll prep him for cath lab.
Hey, Mr. Samba. You're gonna be okay.
Again, stop saying they're gonna be okay. He just arrested. That is not a good prognostic indicator. Get him to the cath lab. Say that you're doing everything. Say what you know, what you don't know, what the possibilities are. Do not make promises you can't keep.
No pearly gates today.
Really good pickup, Whitaker.
How are they so confident?
Otter, get here.
You fell at your construction site. A coworker brought you in.
He's a lot better, but doesn't remember anything.
That's common after a concussion or DKA.
DKA?
It's a serious complication of your husband's diabetes.
How serious? Can he go home?
We still have to clear the ketones from his bloodstream.
So we're using a lot of vocabulary, which makes it very difficult for the family to understand what's happening. You're hearing abbreviations, you're hearing words like ketones that are not words that you typically hear, which makes it very difficult during an emotional state to understand what's going on. So explaining that the sugars are very elevated and that leads to abnormalities with certain blood variables, and that we need to get them normalized before getting him home, and that we're moving in the right direction. This is a explanation that people can understand, wrap their heads around, and then when they need to ask for more details moving forward, you can absolutely supply the intricacies.
He'll need to be on an insulin drip for a while until things get back to normal. Best if he stays in the hospital.
It's okay, Mom.
Things are headed in the right direction, Mrs. Diaz. He's going to be better.
Again, making promises is not great. Saying that we're moving in the right direction is perfect.
Oh, do you mind?
Absolutely. So, the thing is, we don't have health insurance. So, I don't think that we can afford this.
I'll have our case manager, Noel Hastings, come by. She's an expert in health insurance. She might have some options for you for coverage.
Yeah, because we definitely do have options for people who don't have coverage themselves, that are living below the poverty line. That's why social work comes in handy in these scenarios, because while we as doctors want to help in a scenario like that to help them get care, if we spend a lot of time managing the social situation, we're not dealing with the medical situations that other patients are coming in with. So this needs to be a team-based approach.
So now what?
You can wait 1 to 2 weeks for the super glue to break down on its own.
I'm hosting a 4th of July party tonight. You want me to show up like this?
The other option is I trim your eyelashes
We said that in the earlier episode.
halfway down. That'll lower the strength of the glue holding them together.
Let's do that.
Lie back, please.
Got to be really careful with sharp objects around the orbit.
I need you to hold your head perfectly still. Keep your eye closed.
My eye can't open. That's why I'm here.
No, I mean your other eye too.
Because when you signal to open one eye, it moves both eyes.
Okay.
I also don't like the angle that he's going on. The bottom edge is the safety edge, so I would use that to get underneath the eyelashes.
Hi, Miss Ronson.
Alicia, please.
She's still very tacky at 104. Not very tacky, but tacky given the fact that she's at rest with supplemental oxygen, normal O2 set. Her respiratory rate's also 20. She's breathing quick.
I've had this pretty bad cough for a few days now.
Do you smoke? Are you coughing up anything, any chest pain?
No, no, and no. I honestly think I picked it up at work. It was going around.
It could be an office bug.
Or I got it from the gym. I'm there all the time.
Lung sounds are going to be really important here.
Okay, what'd you hear?
Maybe some crackles at the right base.
Okay, well,
We're gonna need a chest x-ray to check your lungs.
To see if she has a community-acquired pneumonia.
How are we doing in here?
Oh, this is thrilling. Definitely worth $200,000 worth of student debt.
Superficial ones get a steri strip, full thickness triderma bond. How can you tell they need a suture? Joy.
If the edges are under significant tension?
I didn't realize your name was Joy. I'm gonna have to tell my parents how trendy they were.
I love this battle that's happening. See, as attendings, I would step in here.
CT, head, neck, chest, abdomen, pelvis, all normal, and pulmonary
Lucky
range.
guy.
A little bit of oozing.
Pressure for 2 minutes, lidocaine and epi if that doesn't work.
Lidocaine and epi is a treatment to decrease bleeding in an area like that because the epinephrine constricts the blood vessels, decreasing the bleeding.
Are the admin orders in for surgical ICU?
Oh no, I hope she didn't get poked because now she has to go to occupational health. And unless the patient has very clear results from this visit or wishes to get results for certain communicable diseases, she might have to get post-exposure prophylaxis, which is not fun.
This.
The first thing you should do is wash your hands as quickly as possible in these scenarios because that decreases transmission risk the most.
No past records on this guy. We don't know HIV or hepatitis status.
I'll put the orders in, HIV antibody, hep B surface, and hep C.
And they're washing it with saline, it looks like, but you could just run this underwater. It's the same principle.
Thanks.
The new radiologist is a hottie.
Side note.
His head CT is normal, as are his blood and urine tests.
Then what's wrong with him?
We're not sure yet. There is another test, a spinal tap. So this could be an infection in the fluid that surrounds the brain, viral encephalitis. It can also cause altered mental status and confusion.
Can you treat it, if it is?
Yes.
It would be a very unusual presentation, but absolutely can happen with altered mental status. So in a patient where you can't get a thorough history, a lot of times you have to do more tests, sometimes invasive tests, in order to get a clear answer.
Just what we thought. It's a fracture of your coccyx.
Oh, the tailbone. You're gonna need a donut pillow. That's gonna hurt for a while.
Do I need surgery?
No. These heal pretty well. But it'll take about 6 weeks.
6 weeks?
I was gonna say 8 weeks, especially in an older population where the healing is not as great as if you were 18 years old.
Is there something else you can do?
Well, there is a procedure to push the fragments back in place.
Oh, is this the internal one that you have to go rectally? That's not one I've ever learned.
Do what you must, my lady.
Okay, first I need to get a good grip for the reduction.
Interesting. I have never done this, but I guess it can be done. This is high level.
Here we go. Try to relax.
Oh, I like that this is embarrassing bodies level of footage here. That is a show that was shown in the UK, which allowed people to see that we all have human bodies, and there's no need to be embarrassed.
Got it. Now on 3, okay?
This is not going to be pleasant.
You son of...
I know. Sorry, it keeps you from tensing up.
I'm surprised ortho's not involved in this.
Oh, my God.
Take off the glove.
Both parents work, but neither of them have health coverage?
Orlando and his wife have multiple part-time jobs that don't offer insurance.
Can they qualify for Medicaid?
Unfortunately, no, because their combined annual income is over the Medicaid threshold for a family of 5.
So they make too much money?
And not enough at the same time. They live over the poverty line, and yet they are still living paycheck to paycheck.
People fall through the cracks like this in our healthcare system so often. That's why bankruptcies are skyrocketing in this country related to medical debt.
I think their best option would be to buy private insurance through the Affordable Care Act,
which is becoming more and more expensive as the days goes on. There are some hospitals that are non-for-profit that have charity care systems, but again, usually this is reserved for patients that have a very low income. So in a situation like theirs, they may not qualify for the charity care either.
How is he?
He's stable. He's doing great.
Doesn't look great. Is there brain damage?
The head CT showed no bleeding or skull fracture.
But you won't know until they wake up and you can do a clinical examination, and you wait to see if there are some deficits, how quickly they improve.
It's most likely a bad concussion. It's hard to know when he'll regain consciousness.
But even with a bad concussion, you can have neurologic symptoms.
Chest and abdomen CT scans also showed no major internal injuries.
What's that?
We need respiratory.
Why is he so excited about this bleed?
Okay. 1, 2, 3, over. Yes.
You have a problem with the vent?
No, he's bleeding from the back. Gotta prune him to take a look. Back away, Tanya. 1, 2, 3, up. 1, 2, 3, over. Good. Oh, shit.
Okay, left flank area.
Careful, careful, everybody. There might be glass.
2 centimeters simple laceration. Open a suture kit, 4-proline.
It wasn't bleeding when we flipped him on arrival.
No, but when we moved him around for CT, it might have rubbed off a clot. Slow venous oozing.
It's good that it's venous flow, which means that it's slower. When you have arterial flow, it's pulsating, it's fast. You could lose a lot of blood very quickly.
Yeah, a little piece of glass in there. It's just under the skin.
Oh, you gotta be careful with the glass. What do we say when we watch The Good Doctor? Never pull it out.
Yeah, I can wiggle it around. Here, I'll pull it out.
No, don't.
Oh!
Shit.
Okay. It's bigger than I thought it.
That looks arterial.
So that piece of glass was actually putting pressure on the artery, stopping it from bleeding, and removing it stopped that tamponade effect, and as a result, he's bleeding out. That being said, once you open it, you should be able to clamp off the artery, but now the patient's getting an unnecessary procedure. Probably still would have had it, it just would have happened under way more controlled circumstances.
I can push it back in.
No, my God.
Damn it.
Well, should I keep pulling it out then?
Absolutely not. The glass was tamponading a vessel.
Not anymore. BP's down. Page surgery.
God, what artery was it putting pressure on? Renal?
Pressure's up with 1 unit type specific.
What the f? He was stable.
Slight change in status.
Okay, get the clamp ready.
Who's the genius who pulled that out?
I thought it was a loose fragment.
Next time, leave the decisions to the adults.
Okay, Dick. Okay, ready to go?
Oh, that's a deep, deep piece. I'm surprised they didn't see that on the CT scan where he said everything is normal. Very, very unique.
Okay, I am injecting the X-Stat.
Hello?
What is that?
It's a syringe filled with tiny, rapid expanding hemostatic sponges.
Putting pressure on the area where there's blood loss in order to get him stabilized to go for surgery.
Radiology attending says the resident missed something. There's a radiopaque foreign body in the left paralumbar musculature.
Why is the student reading the scans? Do they not have radiologists?
Sounds like first week in July syndrome.
Except he's not a resident, so he shouldn't be the one reading the scans. This is a classic issue in this Pitt hospital where they let students just do all sorts of decision-making moves that I don't support.
The x-ray came back on the lady with the cough. Weird infiltrate. Have you seen it yet?
No, I've been trying to catch up on my charting.
Here.
Yep. Stringy right lower lobe.
Yeah, it looks like aspiration pneumonia.
Why would she have aspiration pneumonia? That's a bit strange.
Think about it. How do oral and gastric fluids end up in lungs?
Vomiting?
Dysphagia, swallowing disorders, but she's not an old person choking on their food.
Right, and there's protracted vomiting.
Okay, maybe recent gastroenteritis, food poisoning.
I mean, you can't know that for sure from just looking at the x-ray. I don't know how they were able to very clearly denote that this is an aspiration pneumonia.
Or an eating disorder.
Think she's bulimic?
I mean, she's fixated on working out. Check the enamel behind her front incisors.
So dental erosions can happen with someone who's vomiting often, and bulimia doesn't always have to involve vomiting. It's more about consuming a large amount of food and then feeling negatively about that, leading to some sort of compensatory mechanism, whether it's vomiting, forced vomiting, exercising excessively, or restrictive eating patterns.
Any improvement?
No.
What kind of super glue did you use?
Doesn't matter, my eye is still shut.
Okay, there's one other thing I can try.
No, I'm done. I asked for Dr. J earlier, and I would like to see her now.
I haven't been in the hospital for a while. I don't know a Dr. J.
She's one of the best doctors in Pittsburgh.
Is she gonna show someone from like Grey's Anatomy?
Oh, Dr. J.
She's not a doctor.
Aspiration pneumonia. How does that happen?
It's when bacteria from the mouth or stomach get into the breathing tube when you're choking, if you're eating or vomiting.
Oh. Do you ever drink a lot of alcohol? Maybe so much that you pass out?
No, I'm not a big drinker.
Have you had the stomach flu recently? Food poisoning?
Why not just ask if the patient has vomited recently instead of finding ways to ask around that question?
Do you mind if we take a look inside your mouth? You can lean your head back and open wide.
What?
The enamel on the back of your teeth is worn away.
What does that mean?
It can happen if someone makes themselves vomit repeatedly. All the stomach acid dissolves the enamel.
What does that have to do with having pneumonia?
It may have caused it.
Can you just give me some medicine?
Yeah, we can do that.
I don't like the sequence of events that happened here because it looked like they were trying to find evidence to confront the patient. Whereas this is the patient's own body. There's an infection, you treat it. You want to ask the patient questions to help them prevent this from recurring, you can, but looking for evidence to catch them in something is not necessarily the best approach.
What if I have been making myself vomit?
Bulimia nervosa is a condition that usually is treated with sometimes dual approaches, but cognitive behavioral therapy, there's enhanced versions of it that can help individuals, but also there are pharmacologic options, especially for adults. For adolescents, it's not as well proven, but there is some promise there. But yeah, it's like a full team approach in those scenarios, and understanding that sometimes there's comorbidities that can come with a diagnosis of BN related to depression, anxiety, obsessive compulsive disorder, etc.
Bulimia is treatable.
I was gonna stop. I stopped before. My family gathers around food. We eat when we're celebrating, we eat when we're mourning, we just eat. But then I got to college and it was all about how you looked.
That's a lot of pressure.
Validating the patient is so good there.
I started vomiting. Everyone said I looked great. So I went to the gym more. I didn't need to purge as much. Last year, I went through a breakup. It all came back.
And shame is this added layer of complexity on top of having this condition. And remember, this is not just a psychological condition. This is also metabolic because it can impact electrolytes, can cause dehydration, and those electrolyte shifts can be problematic, even deadly at times, obviously in more extreme cases.
Dr. J, finally.
It is so nice to meet you, Dr. J. This is Willow, your new patient.
I'm actually a student, doctor.
I watched all of your videos. The one about coping with difficult coworkers was super helpful.
Hold on a second, is she a YouTuber?
So what is Willow's health issue?
My eye, it's super glued shut.
Halfway trim and mineral oil didn't work.
Nope.
Then I would suggest cutting the full lash down.
I concur, Dr. J.
Is that her handle?
Here we go.
How many followers do you have, Dr. J?
A question that's never been uttered in a hospital emergency room, except with Dr. Beachgem, of course.
More than you'd guess, Dr. Langdon.
Wow, that was the most confident I've seen her.
I heard you had a motorcycle crash come through about an hour ago.
Yeah. Couldn't save him. I know he was not wearing a helmet.
Interesting.
One motorcycle crash is not going to scare me off my trip.
I didn't say it should.
I hope he died doing what he loved.
That's optimistic.
I am not on your couch.
I'm aware. Conflict of interest here.
Why, because we're friends?
Oh, look at you. Using the F word. It's growth.
I use F words all the time. I guess this therapy must be working.
It's great that he's getting therapy and understands that it could benefit him because a lot of times healthcare providers, especially frontline healthcare workers, will be reluctant to do so for fear of judgment. Judgment onto themselves that they project. So this is reassuring.
I got somebody new for you. She takes no shit. You'll love her.
I hope so. The last two have not exactly been my speed.
The connection between the patient and the therapist is one of the most important variables that decides whether or not there will be a good outcome. There's also situations where someone's going through so many therapists that someone, usually the initial prescriber of the referral for the therapy, needs to ask the patient if this is something they're actually interested in, because repeated therapy failures can actually lead to recurrent therapy failures, so that needs to be investigated.
How are you feeling, Mr. Diaz?
Much better.
We need to talk about how your diabetes progressed to this place. Is this student Dr. Juan? What you say here remains between us.
I'm taking a lower dose of insulin than I should be.
So this is a real scenario where patients try and ration their medications because they can't afford the full doses. And with insulin, that is a non-starter because as you've seen here, if you ration your insulin in an uncontrolled way, consume too much of a certain food, you can get your sugar levels to a point of diabetic ketoacidosis, which usually requires an ICU stay.
I used to have insurance through work, but I lost that job when the pandemic hit. It was easy to keep up with my medication then. I had a great primary doctor too. Now I'm kind of on my own.
So there are other alternatives instead of using the long-acting insulin that he's probably taken. And while it is most convenient to take that, sometimes it can be expensive. We have intermediate acting insulin, which is sometimes cheaper, that we then can pair with bolus dosing insulin with mealtime. A lot of clinics that I worked with where we have patients that struggle to pay for their long-acting insulin, that was a strategy that we used.
Can we not talk about this in front of my family? They're my girls. Did you call your brothers?
They're still at soccer. I have good news. I started a GoFundMe for Dad.
A what?
To help raise money for Dad's medical care since we don't have insurance.
That is unfortunately how a lot of Americans are paying for their medical care. There's actually been articles about it. And it's truly disappointing that that's the state of our country as it exists today.
I got a bounce back. You remember Debbie Cohen?
Not really. I've seen 16 patients this morning.
The restaurant worker with cellulitis on the dorsum of the foot?
Yes, she's on Keflex. I marked orders.
Yeah, I got a hot pack on it, but you should take a look.
A hot pack?
I wasn't expecting to see you back so soon. Meds upset your stomach?
No. The pain got worse, and you said to come back if the redness spread outside the Sharpie line.
That's important because the cellulitis could be spreading to the joints, to the bone, creating an osteomyelitis.
Let's take a look.
Ooh, Erbsillus?
It looks like the infection isn't responding to the pills I prescribed you.
So she's gonna need IV antibiotics. I don't think it's actually Erbsillus.
We need to get you on some IV antibiotics and get you back to the ED now.
Is it bad?
Not if we can get a handle on it. Worse? Or maybe worse.
Maybe worse than what? The hospital could not stop this nurse from killing. Click here to check that out, and as always, stay happy and healthy.